Okay, well, it's always indeed a great honor to be invited. I'd like to thank you, Ashwin and Gaurav, for your invitation. Very honored to be speaking among such great speakers. I'm going to show a video instead, just to save time. I'm going to switch location now to the cornea, and I'm going to share with you how to do femto LASIK cut in very small eyes and see whether we can do it even without suction. I have no financial interest related to this presentation. In small eyes, it is very difficult to apply suction even after lateral canthotomy. In microkeratome, you never cut the flap if you don't have proper suction. But if we cannot get proper suction, can we perform a femto flap cut? Well, let's see. This is a first case, a 44-year-old lady who's only 5 feet tall, very small palpebral fissures. She's a moderate to high myope. She has presbyopia of plus 1.0. We plan the wavefront optimize in the right eye and custom Q treatment in the left, aiming for -1 for monovision. Her eye is very small, and I couldn't get it in properly, even with a lot of hard pushing, and couldn't get proper suction. I'm checking the lid margins, making sure the lip of the suction ring is under the lids. This is my first case, and the patient's moving all over the place, as you can see. So I asked her not to move. I applied a little bit more pressure down, see if I can get suction. I couldn't, and it looked okay according to the yellow ring on the screen, which plans your laser cut. But as you see, the patient was moving while I performed the LASIK cut. And obviously a VGB occurred as well, and nothing could be done. I didn't do the side cut. If you don't do the side cut, you've not created a flap. You've really just done a lamella cut, okay? And as I said, the cut was done without suction. And the VGB obviously stopped me from going on, and we immediately did LASIK with MMC with the left eye. And let's take a look at the results. At 1 month, the patient has recovered now to 20/20, best corrected, and it does take that long even with normal eyes when you do LASIK. And at 1 year, she's 20/15 best corrected in an eye and little under corrected, but she's 20/20 in both eyes and J1, and the patient is happy. This is a second case, again a small lady, 5 feet tall, 35 years old, planned wavefront optimized, moderate myo with LASIK planned, and now I have more experience. And if you look at this, I'm putting in the ring, and I actually tried it to see if I can do it, but it just wasn't sitting properly. So I used the Q-tip and I check. You can see that the lashes and the lid was over the lip, and this one you can see the suction lip right here is above the lashes. So I roll the lids out, roll it out, and I slip the lip under, and I check the meniscus right here. You can see there's still a little bubble right here, so I'm not getting really proper suction. Right here you can see it is still, the meniscus is here, but there's still some bubble right here, so I'm not getting a proper contact. Here we are again. So I thought I had good suction. I'm applying the cone down, okay, and didn't work. Okay, I lost suction. So I did it again. Okay, this time I'm pushing down on the eye with my hands, on the ring, to keep the pressure down while I'm applying the cone. So I'm making sure I don't lose suction. But again, I lost suction. You can see the eyes moving all over the place. Here I got the patient stable. I actually paused for a while. This is speeded up. And I kept the patient not moving, and I did the cut. And after the cut, I still made sure the patient wasn't moving. Then I continued on with the side cut. So you can pause and take another look before you do the side cut. If you've not done the side cut, you basically have not made a flap. So we tried, as I mentioned, suction, keep breaking. So I maintain a constant pressure on the suction handle and then instruct the patient not to move his or her eyes and head. And as you can see, the stromal bed is nice and smooth after lifting the flap. Post-op 1 day, 20/20 vision in both eyes. So, can we perform femto cut without suction? What if the patient moved? Well, in microkeratome you have a free cap, but in this you don't, especially if you haven't made the side cut. And even if you cut to the surface, the flat has not been dissected, so it's not going to move. The only potential problem is if the cut approaches the surface while it's bisecting the visual axis. Well, the cut is so fine, it is unlikely to cause any scarring or visual loss. And it does take a few seconds to reach the surface. There should have more than enough time for the surgeon to stop the laser. So interlace can be done without suction. Make sure the patient's eye don't move. Pause a few seconds just to check the patient hasn't moved at all before you start the cut. And if there is a problem, if the eye moves, the patient just moves his head or her head, then you can just stop and don't perform the side cut. Use the same cone, recut at the same depth, or go to 40 micron deeper or shallower. Convert to microkeratome if no side cut is performed, or you could do LASIK with MMC as we did with the first case. And for very small eyes, perform a canthotomy. Do not use a lid speculum. You roll the eyelid outwards and slide the lip of the suction ring under the lid with a cotton tip applicator. Thank you. Sorry about the sound. But I just have one thing to add. With very small lids, it's so tight, you cannot even get the Q-tip to kind of to move the eyelid because you got to move like this. So the best thing is put it there and just roll the eyelid. You use the Q-tip to roll the eyelid. The nice thing is when you roll it, it actually everts the lid and lifts it. You can go under, put the lip under the lid. So that's that one little trick for getting the interlace, the lip under the lid that I acquired. I find that very helpful.
I think that's extremely beneficial. And I think there's so many other advantages to knowing that simple knowledge, even in cataract surgery, even if you want to put a speculum in, or so many other aspects to it.
Yes.
And layers to that. Thank you so much, John. That was brilliant. And that was such a complicated case. I would have just said abort. Gaurav, all to you. Thank you, John, for that.
We'll be back, John. Some questions for you. So
sure.
I think